Okay, great, great. Okay, yeah, with that, we will begin. So thank you for everyone for being here. Thank you to all the students all over the world for attending this lesson. And and just as a quick recap on paper, we will be studying, first of all, the structure of the heart. So this might be slightly less relevant to the engineering aspect, but it's important to understand for when we are looking at diseases of the heart to understand how does blood flow in the heart, to understand how do we engineer different parts of the heart, and also look at the valves of the heart and the different parts of the heart and what make the heart, well, the heart. Next, we'll be looking at diseases of the heart. So we'll be looking at things like hypertension, coronary artery disease, heart attacks, strokes, things of that nature. Well, strokes can be caused by heart attacks, but we'll get into that. And then we'll look at solutions, so ways that we can kind of bioengineer around this and address these kinds of issues. So with that, we will begin our lesson. So before we go into too much detail, I just want to give a quick warning for everyone that if you've never seen a heart diagram before, and some of you have, but if you've never seen a heart diagram before, this might seem complicated, it might seem daunting, but that's completely normal. That's completely okay. So just I say that with a grain of salt. That just take it with a grain of salt. Don't get too intimidated by it. But it's a fairly simple diagram. So I'm going to be showing this same diagram and looking at it in 5 different ways. So again, if you don't get it the first time around, you'll probably get the 3rd or the 4th or 5th time around. So don't worry about it too much. So I'm going to start off by making a set of the observations. So firstly, the heart is divided into 4 parts. So my observation is that if you see here, here's part 1, part 2, part 3, part 4. So in general, if you look at these top parts, they're called atria. And that kind of makes sense if you think about it a lot. Like if you think about like a way to remember it is that, well, A is the first letter in the alphabet, so A is on top, and these bottom chambers are called ventricles. And that also makes, V is much lower in the alphabet, so it's lower on the heart. That's just a quick way to remember it. So in general, the heart has 4 chambers. So blood goes in through these 4 chambers and circulates through these 4 chambers. So the basic goal of the atria, these chambers on top, are to receive blood. So they either receive blood from the rest of the body or they receive blood from the lungs. And we'll get into that soon. And the purpose of the ventricles, if you look at the ventricles, they seem longer. It's the reason for this is that there's a physiological purpose. The reason for the ventricles being longer is that the ventricles pump blood. So that's another observation, right? So the A's, the atriums, receive blood, and the V's, the ventricles, pump blood. It's a very simple, basic observation I'm making. So next, one thing I'm sure you've noticed in this diagram is that it seems like right is on your left and left is on your right, and that's not a mistake. So this is common. This is the common kind of language convention in medicine, because when I imagine that you're a surgeon looking into a patient, right? You're a surgeon looking into a patient's heart. So the controls are reversed, right? Left and right is reversed. To give you an example, if my patient was standing back to me, then my left and the patient's left is aligned, right? This is everyone's left that's looking at the screen. This is everyone's right that's looking at the screen. But if my patient is the other way around, right? If my patient is lying down, because we never do heart surgery from someone's back, right? Because their spine is in the way. So when my patient is laying down on the table facing me, then even though this is my left, this is their right. And even though this is my right, this is their left. So does everyone see that? This, if their back is to me, our rights are aligned. But then when they flip around, then that right goes to our left. So that's why even though this seems like, this should be the left atrium, this should be a left ventricle, this is the right atrium, this is the right ventricle. Just a quick notation to get straight. Then the next observation I'm going to make. So it seems like the left part of the heart is blue and the right part of the heart is red. So I just want to make a quick observation that we do this for educational diagrams. In reality, blood is not blue. Blood is obviously red because of the iron that we see in it, that we see in our hemodynamic cells. But we do this for educational purposes. So we need to understand, well, the blood that you see as blue is deoxygenated. It does not have oxygen. Oxygen has been used up by the body. And the blood that we see on the right that is very red is oxygenated blood. So this blood has oxygen in it. So there are 3 main players in this interaction. And I will get into this in depth. We have slides on this in literally 2 minutes. But the 3 main players are the body, the heart, and the lungs. The body uses oxygen. So the body creates this deoxygenated blood. right? So when I run, when I speak with my lips, when I move my hands, right? These are all actions that expend energy. And that transactional currency that we expend for energy is ATP, and we can get into that with cellular respiration, but we don't need to. That's not important. But a part of that is using oxygen. If anyone knows about cellular respiration, if you've learned it in school, this is the part called oxidative phosphorylation. Essentially, our body needs oxygen to fulfill basic functions. So when our body uses up oxygen, then that blood goes to the heart and says, well, I have nowhere to go. I have no oxygen. I need oxygen. So then the heart says, okay, and then they redirect the blood to the lungs. So the lungs has oxygen exchange, where the oxygen you're breathing into your lungs actually goes into your blood, and then your blood releases CO2 to your lungs. So that's why when you take a deep breath in, your lungs fill up with air, but with oxygen. But when I breathe out, right, when I sigh out, exhale out, sorry, everything that's released is CO2, because when I inhale, all that oxygen goes to this deoxygenated blood and turns it red for the purposes of the diagram. And then this blood, this deoxygenated blood, releases carbon dioxide to my lungs, which I then exhale out. It's a kind of beautiful system. So some of you might be thinking, you know, what is this? What does this random GIF have to do with anything? So I want you to think of this, you know, squishy plushy toy in terms of the blood. So this is kind of another analogy to look at how the blood carries oxygen and releases oxygen. So you can think of it as every time I'm squishing this plushie down, it's like the blood is releasing oxygen. So the blood is deoxygenated, and then it goes to the heart and goes to the lungs to reinflate. And that analogy for the reinflation of this plushie is gaining oxygen. So it goes to the lungs to reinflate and gain oxygen. And then when it gets smushed down again, that's the analogy for you know, the oxygen getting used up by the body. The oxygen gets used up by the body, and then we get oxygen from the lungs. Gets used up by the body, and then we get oxygen from the lungs. That's a very basic flow. And the basic circuit, the three main fluids in the body, the heart, and the lungs, I'm going to break that down and kind of show you how all the different parts of the heart are involved. So it's a little less important that you know all this and memorize and everything. I'm just saying this to give everyone a general idea. So, you know, if you do memorize it off the bat from the way I'm explaining it, fantastic. But if you don't, that's completely okay. For our intents and purposes, the way we're looking at the engineering modalities of the heart, you don't need to memorize it. Just understand how blood flows. That's the important part. So firstly, we have blood that goes from our body arteries, that gets expended from my body, from me moving my arms, from me running with my legs, and that all goes right to these arteries in the heart. So these are called like the vena cava. But essentially, they go into the heart, and they go into the right atrium, the right ventricle, and then they circulate through the heart, and they actually go to the lungs. Does everyone see that? I've used up all the energy, I've used up all the oxygen from the blood. They go to the heart, and then they go to the lungs. So now that they don't have oxygen, they go to the lungs to get oxygen. So then they return from the lungs. So now that they've gotten oxygen from the lungs, they return from the lungs and go back to the left atrium and the left ventricle. So now you can see the blood is red because they've received oxygen from the lungs. So now they're in this this portion of the heart. They're oxygenated. They have oxygen, and now where should they go? Well, that's completely right. They should be going towards the rest of the body. So now that they have oxygen in them, now the rest of our body can use that. So then this is a self-repeating cycle, that our body gets fresh oxygenated blood. So that when I need to speak, when I need to move my hands, when I need to run, it gives oxygen to my legs, my tissues, my arms, and everything for me to move and do my daily activities. And then that whole cycle starts again. That I expend energy through the body. That goes to this side of the heart. Then that pumps it to the lungs. Then the lungs give it oxygen. And then that oxygenated blood goes all over the body. And again, you don't need to memorize it. I don't expect you to know the names, left atrium, right atrium, what are the vena cava, whatever. I don't need you to know that. All I need you to know is this general idea of how the blood flows and why it flows the way it flows. So the next observation that I want to make is that if I was to take my heart and make a cut this way, if I just cut it open like we were in anatomy class, and I was to peer into this cross section of the heart, I would see an image that looks like this. So there are things called valves in our heart, and some of you may know this, some of you may not know this. So I'm gonna pretend that we're starting from scratch. So the valves of the heart are what's responsible for the noises of the heart. So when you hear a heartbeat, you hear this lub-dub noise. So that lub-dub noise is actually the valves opening and closing, opening and closing. So the reason why we have valves is to direct blood in only one direction. So you can imagine what would be why it would be bad for the blood to flow backwards instead of forwards. If it flows backwards, then there'd be extra blood in our hearts that shouldn't be in our hearts. Then that would mean that the heart isn't able to fill up as well. That means the heart would have tons of issues, and we're actually going to study some diseases related to that. But it'd be a very bad thing, and that would mean that there's less blood for our organs, less blood for our tissues, and that might lead to death in the organs or death in tissues in my arms or legs or brain or whatever. So that's why it's very, very important that our valves function correctly. And another metaphor or analogy for a way that we can look at the valves is a one-directional door or stop signs at traffic lights. So for students in Ghana, this probably looks right because you know, you drive on the right side of the road. But for students and from Zimbabwe that are joining us either later offline or right now online, in America, I'm using American convention, but we have the cars on the right side instead of the left side. But nonetheless, the point is still the same, that when we're at a four-way stop or something, and we have two cars going, the purpose of the stop sign is that, well, one car should stop while the other car goes, because these cars otherwise would collide. And then once this car goes, then this car can go. And then it's like a one-directional flow kind of thing. So you can imagine what would be the issue if the car traveled backwards, right? It would crash into other cars. That would be a very bad thing. But also another purpose is that so all of these streams of cars don't coincide. So again, one car must stop so the other car can go, or this car might stop so this car can go. So that's basically how that works. So likewise with the heart, we have certain valves that are open so we can have directional flow for, let's say, towards the lungs, and then maybe certain heart valves will be closed so we don't let the blood in at the same time. So it's just a very streamlined one-directional flow. So valves are very, very important in the heart. And I don't once again, it's not important to memorize the names of the valves and everything, but this is to kind of show you where the valves are. So between every atrium and ventricle, there's a valve, and going from the ventricle to, the lungs, or going from the ventricle to the rest of the body, there are valves separating that process as well. So that's how we get like the very segmented 4 chambers of the heart, where we have valves separating, different parts of the heart. So that's just one thing to keep in mind. So now that we understand the basics of the heart, and again, hopefully that was pretty painless. We covered it in 10 minutes, very quick, but just giving you a general gist of it. Now we can go into a case study. So this is Meryl. So Meryl is a loving aunt, and this is another case study like we did last time. Meryl is a loving aunt, and she's been suffering from diabetes and being obese for a few years now. So usually these are 2 big indicators: having diabetes and being overweight for heart disease. So the dangerous part about heart disease is that it often goes unnoticed. So in Meryl's story, she didn't notice that she had heart disease until she had small chest pains called angina that she didn't even notice. She wrote off as maybe soreness around the chest region. And one day she found herself being very diaphoretic. So that's a medical term. It means that you're out of breath, you're very exhausted very easily by doing very minimal activity. So just from the action of walking from her backyard to her garage, she found herself completely out of breath. She found herself sweating. She found herself feeling a very burning sensation around her chest and trouble breathing, that every breath felt like there was an elephant on her chest. So when she went to the hospital, she got her blood pressure taken, and she saw that her blood pressure was very, very, very high. It was 200 over 120, which is much higher than it should be. So then she discovered that there are 2 possible issues that could happen with her heart. Firstly, one issue could be that the coronary arteries, so the arteries that lead blood to different regions of the heart, could be clogged. So as a result of this, she could have hypertension, and we'll get into that. And a second issue could be that the valves and the muscle in our heart are failing. The very valves that open and close to let blood in and out are failing, are either degenerating, or they are obstructed or clogged, and we'll get into those scenarios. So being a good doctor, which her doctor definitely is, they go and take it on a case-by-case basis. So let's say that she has obstruction of the coronary arteries. Let's say the arteries that bring blood to her organs are obstructed. So before we can even delve into that, I want to give a set of analogies for us to understand why this is a bad thing. So let's say you are, drinking soda. Let's say you're drinking Coca-Cola out of a straw. Then let's say you use each of these straws individually. Let's say you use this big straw with a 1 millimeter diameter. So if I'm drinking Coca-Cola with this straw, it comes out nice and smooth, quick and easily. If I was to use this smaller straw that has half the diameter, what would happen? Would I have to suck harder? Would I have to suck less hard? What would happen to the pressure I would have to exert? And how much of the Coca-Cola is actually coming into my mouth? The answer is obviously, as most of you can imagine, I would have to exert more pressure with my mouth. I'd have to suck a lot harder to get the same amount of Coca-Cola as I would with, you know, a normal sipping motion with this straw. So I'd have to sip a lot harder, and in addition, I would probably get less Coca-Cola, right? I would get less Coca-Cola and have to put in more energy, more sipping. So that's bad. And another analogy for this that I think is more apt to is like for blood flowing through veins or in arteries is like water flowing through a hose. So if I'm watering my plants, again, if I'm watering my plants and this is unobstructed flow, then look at how the water is going out of the hose, right? It's a kind of weak flow, it's a steady flow, it's a normal flow. But what happens if I was to put my thumb inside the hose? Like I was to obstruct half of the hose. Well, then the water spurts out a lot faster, right? And I'm sure everyone has done this at some point. Hopefully everyone's watered their garden at some point. That if you obstruct part of the hose, like half of the hose with your thumb, the water spurts out a lot farther and a lot faster, a lot higher rate. So although this is good for gardening, this has very, very negative implications when we're looking at the heart. So when we're looking at this analogy for the heart, you might think, well, isn't it a good thing if, you know, blood goes faster or blood goes, yeah, there's more force to the blood because it goes faster to all areas of the organs. And that's a reasonable assumption. That's what I used to think initially. But the reason why this is bad is multiple-fold. So firstly, because of this increased demand, right? Because you're going from this to this, like a faster flow that's more vigorous, then your heart has to work a lot harder to keep up with the blood. So your heart has to start beating faster. And if your heart starts working too hard, that can damage heart tissue, and that can actually thicken heart tissue. So this isn't the exact way this happens, but a good analogy for this is if I'm working out, right? So if I'm working out and lifting weights, what happens to my muscles, right? My biceps begin growing. So as a result, because my biceps are growing because of repeated use and repeated, you know, I keep working out, that muscle there thickens. So likewise with the heart muscle, it's just the same. It's just a muscle, right? So if I overwork it, then your heart muscle can thicken. This might, you know, some people have a misconception that this might be a good thing because your heart is stronger, but that's not the case, because if your heart thickens, it becomes more rigid. A beautiful part about our hearts is that it's elastic. It can beat fast, and it can beat very fluidly. If it thickens, then it doesn't fulfill the same role of delivering blood to the rest of our body. The second bad thing that happens is that, well, you can imagine if I have a steady flow versus a more rigorous flow, when this goes to my organs, when this goes to my brain, when this goes to my kidneys, when this goes to my liver, when this goes to my lungs, that's not good for these organs. So this faster blood flow can actually damage organs. It can lead to conditions like hypertrophy, where the organs enlarge, but cause damage in the body. It can also tear heart tissue. So there's a condition, again, the name isn't important, but the condition is called aortic dissection, where essentially the blood flows so fast that it cuts into the aorta, it cuts into the heart tissue, and starts a new stream of blood into the heart tissue. That leads to hematoma, that leads to blood pockets being formed in the heart where there shouldn't be blood at all. And that can cause heart attacks, and that can cause damage to the heart. So before I go on any further, are there any questions? I know we are kind of breezing through the heart anatomy a little quickly. So if you don't have any prior knowledge of the heart anatomy, I can totally understand if it's confusing. So if anyone has any questions, I'm more than happy to answer that and take a quick 10-second break. Okay, looks like everyone has a good grasp on it so far. I'm glad to hear that. But yeah, if you have a question, please type into the chat. I'll answer it even if I move on. So no rush there. But yeah, so clearly we've established that with hypertension, with this disrupted blood flow, it's bad for the body, it's bad for the heart. So now this can happen in two ways. So this can happen by the actual blood vessels thickening, or this can happen by sediment and plaque in the blood vessels. So an analogy for this with the hose would be either my hose itself can thicken, which would lead to, you know, if my hose thickens and gets narrower, then the blood flow is going to increase. Or if I have obstruction, if I have plaque, imagine if I had tiny plaques or obstructions within this hose, then again, I would still have this faster blood flow known as hypertension. So the first way this happens is called arteriosclerosis. big word. We don't need to memorize it per se, but all we need to know is that the actual blood vessels thicken, and they lose their elasticity. So again, I said that a beautiful part about our heart system and our arteries is that they're elastic. They can grow and expand very easily. They're more flexible. If they thicken, then we have hypertension. That's a bad thing. And then the second thing that can happen is atherosclerosis. So what happens here is that there's sediment, there's lipid material, there's plaques, like cholesterol plaques that form on your heart. So when people say, don't have fast food like McDonald's, don't have greasy food, don't have oily food, this is what they mean. Because if you have food that's high in cholesterol, that's unhealthy, that's fatty, then these plaques build up across your heart and build up across your body. And a result of this, they constrict the blood flow. It's the same thing as if I put my thumb on that hose. So that's what happens to your blood, essentially. It's like putting a thumb on your hose, and then that blood rushes faster through your body, so damages your heart, damages your organs, and that's a very bad thing. So there are many risk factors for this. Obviously, the biggest one is lifestyle. Like if you eat unhealthy, if you don't exercise, if you don't move around a lot, it can lead to bad effects in your body. And part of it is genetic too. So if you have a history of heart disease, you're more likely to have plaque buildup. You're more likely to have these kinds of arteries grow and thicken. That's less so of an issue than the way you choose to live your life. And this is just another way to look at these effects and kind of visualize how the plaque buildup can lead to hypertension, can lead to blood flowing faster. So when I say hypertension, think about the blood flowing faster. So hyper means more, tension can look at the tension and the pressure of the blood going through the body. So normally there would be no plaque here. So normally my blood would be going through this is like a cross section of a hose, like water going through a hose, blood normally going through. So if I have plaque buildups, can everyone see here how slowly over the course of time, with every burger I'm eating, with every day I'm not exercising, this plaque builds up around the arteries in my heart, and slowly but surely, if I have a thrombus, which is like a blood clot that breaks through this plaque, and that leads to a blood clot in this area, then that can lead to a heart attack. That can lead to obstructed flow. So imagine, like in this scenario where everything, this is covered by both plaque and blood clots, then my blood can't go through my heart. What happens is my blood can't go through my heart, then all the areas of my body don't get oxygen. So in that flow that we were looking at earlier, of the blood going to the lungs to get rejuvenated and everything, that doesn't happen. So I use up oxygen, it goes to my heart, and then it kind of stops there. So then the other areas of my heart my body don't get oxygen. That can be very, very dangerous. So as a result of that, that's why we want to kind of avoid that from happening. And these are all the effects of this plaque buildup kind of happening. And I'm just saying this for common knowledge in case anyone's interested in this medical component. So again, heart attack and angina. Heart attack is when you have heart tissue death, your heart stops functioning, and you have chest pain. That's what angina is. Stroke is when you see death in brain tissue because of a lack of oxygen. So again, if my heart isn't helping to reoxygenate my blood, my brain isn't getting blood. So how am I going to think? How am I going to function? How am I going to move? My brain tissue is going to die. And transient ischemic attack is when different organs in your body don't get enough blood and shut down as a result and see tissue death. So for example, my lungs, if I'm not giving my lungs new, fresh, oxygenated blood every time, then that's going to harm my lungs. Same thing with my kidney. If I don't give my kidney fresh oxygenated blood, then the tissue in my kidney is going to start to die. I'm going to see cell death, and that's going to be very bad. Peripheral arterial disease. So this is like in the peripheries of your body, the extremes of your body, like your hands, your legs. You're going to start seeing that the arteries there start narrowing and start degenerating because of a lack of good oxygen flow and obstructed flow. And renovascular hypertension. Reno means kidney, so it's kidney-related hypertension. So both it's this increased blood flow, high blood pressure that damages the kidney and hurts your heart as well. So just very dangerous effects overall. Specifically for a patient there. And this is a video that I just wanted to show everybody to show a more concrete example of how when you see this plaque buildup within the heart arteries, then you see less of a space for the blood to go through. And if you see any kind of ruptures in this plaque, then you can see an easy blood clot that obstructs all of the heart. So from a patient point of view, the heart starts having a heart attack. It goes into distress. It can't pump the blood as well, and you start seeing tissue death across the heart. And what does this mean for the patient? What does this mean for the individual? This means that you have to go to an ambulance, you have a heart attack, hopefully make it to the doctor in time where they can go and either perform surgery or give you the proper medication like beta blockers and ACE inhibitors and all that to make sure that you're healthy again and you know, hopefully you are still alive. So now we can ask ourselves a question. Well, I've presented you with a problem, right? I've taught you about two things of the heart. I've taught you about blood flow in the heart and the valves that, you know, let blood through in the heart. And I just told you about a bad issue in the heart when the arteries either thicken or they have obstruction within them. So now we have to ask ourselves, how do we fix this? So there's something called PCI, percutaneous coronary intervention. So the purpose of this from a higher level is pretty simple. That, well, if it's bad that our arteries are going inwards, are tightening, or if it's bad that our arteries have obstructions like plaque, then maybe we can put in a very thin balloon, a very thin kind of line, and inflate it like a balloon. And then, and once we inflate it, then, you know, this plaque can kind of get displaced. This plaque can go to the sides, and this narrowing of our blood vessels will not be narrow anymore. And that's a very logical thought if you think about it. That, you know, if I place something thin within the heart that can easily snake through my blood vessels, that can go to where I want it to go, like the specific artery that has plaque in it or the artery that is thickened, and then if I inflate it like a balloon, then it can create space where there wasn't space, and that can inflate and compress against the artery wall. And there was an analogy, yes, and the analogy I wanted to actually, yeah, let's go to the analogy now. The analogy I wanted to share with everyone is, again, like with the straw analogy. So imagine that, you know, I was drinking drinking something with pulp in it with my straws. Or for those of you who drink milk tea with boba or you know, the tapioca balls, if you're drinking that milk tea, then you might have something that clogs in the straws, like some tapioca balls that clogs in the straws. So a reasonable way of kind of loosening it out is that if I got something to snake within the straw and kind of pierce it and get rid of this boba ball. Or if on the converse side, if my straw was thin, if I had a thinner straw and I was able to put something in there to, like a tiny balloon, to inflate it, to make sure my straw like stays big, stays not narrow, it stays nice and wide, nice and unobstructed, that would be a good way of kind of dealing with that. So scientists first did this with PCI, percutaneous coronary intervention, where, again, yeah, they snaked a deflated balloon into the artery, they inflated it, and compressed it against the artery walls, and had the artery walls reopen. But there came a big issue, because as soon as we, you know, reopened these arteries, then sure, that would work for a little bit. But this was ineffective in the long term, because our patients experienced something called restenosis. So in our example of our patient that we were talking about, restenosis is essentially when, well, I should kind of back up. So this process of our arteries thickening, of our blood flow being restricted, is called stenosis. And even the word stenosis, it sounds like stern, right? Stern is something that's not good. Stern is something that's rigid. So that kind of is a nice way to remember it. So stenosis is when you see the narrowing of these blood vessels. That's all it is. Stenosis is narrowing of the blood vessels. So a nice way to deal with stenosis, they thought, might have been to have like this inflated balloon, and that, you know, gets rid of the stenosis, that rewidens our arteries. But an issue was that they would then re-stenose, they would then re-narrow. So the second we would reopen it, within days, within months, maybe even within years, they would just re-narrow, and then we would have to do the whole process all over again. So from a patient's point of view, right, like the aunt we recovering in the case scenario, that would be a very bad quality of life, having to go in every few weeks or every few months to get this invasive operation where they're literally snaking a deflated balloon through your arteries and to reopen it in your heart. That's dangerous. There's a risk that this can pierce my blood vessels. So there's a lot of risk here. So then we started saying that, well, what if we could address this by putting in stents? So this stent here is this kind of medical contraption. So what if we can snake in this balloon kind of material, we can inflate the balloon material, but also in its place, we could leave this kind of fence-like framework, which would make sure that no matter what, the arteries stay at least this wide. So even if the arteries try to re-stenose, try to close back in, they can't, because there's this kind of metal obstruction there. And lo and behold, they found that this improved the long-term success by 70 to 80%. And that's a drastic improvement. So that saw that, well, clearly this was a successful procedure. And again, the nice thing here is that this is like a small metal, this is like a small flexible framework that I'm putting around the balloon. So when the balloon inflates, it inflates with the balloon, but then it stays in place, right? So it stays in place to make sure that the artery is this wide no matter what. And that did have some good effects, but there was also some negative effects. They saw that an issue was that these would get infected, kind of two issues, right? First of all, these were at risk of infection with bacterial diseases and stuff. But secondly, there's an issue if the cells around the stent begin dividing too fast. So the cells around the stent begin dividing too fast because we see restenosis. There's a chance that the arteries could thicken around the stent and close completely. And that we obviously wouldn't want to do. So that's why we came up with the idea of drug-eluting stents. So to elute drugs means you release drugs. So all this is doing is that it's just the same stent, the same biomaterial, the same biomaterial kind of structure that we use, but now they have drugs infused into their polymer coating. So these drugs inhibit cell division. So by inhibiting cell division, we make it so that the arteries can't grow around the stent. The arteries can't clog up and cause a heart attack, right? Because we've covered, if the arteries clog up, if they grow around the stent and they close and narrow completely, then blood is going to stop in my heart. My heart is going to rupture. I'm going to see cell death, like in that video we were just covering. So by having this drug in this polymer coating, then it prevents the rest of the cells in my arteries from dividing around it. And that's very good because that's been found to stop restenosis drastically. And the results, if you look at it, the results were improving it by fourfold, right? In the control group, which means in the group where we didn't have these kind of drug-eluting stents, restenosis happened 36% of the time for over 1 in 3 patients. And that shrunk by a factor of 4 when we started using these drug-eluting stents. So it was incredibly helpful, a very kind of effective development in the biotechnology field. And I think it also, I included this statistic to show everyone the point that not everything isn't always 100%. So I might say something in the context of a lesson that, oh, when we're looking at stem cells and making a new organ, or when we're looking at even something as simple as a stent within your arteries, it doesn't always go right. It might fail its function, and that's okay. That's part of science. And the part of scientific process is that, well, there's an innovation process that someone innovated and came up with this idea of inventing a stent. There's also an optimization part. Then maybe one of you might think of a better way to have this stent, might think of a better drug to coat the stent with. And because of that, this restenosis might shrink to 4%, or might shrink to 1%, might shrink to 0.1%. And that would be a major scientific innovation. So there are always two components of science, inventing something and improving on something. So just something that I wanted to include for that very sake. So, and this is another image that I wanted to show to kind of illustrate the point of how this works actually within the blood. So these are angioscopies where we're looking at different blood vessels in the heart. And over here, so this is what your blood vessel should look like. It's nice, it's thick, it has lots of space for blood to go through. It's like the nice hose. Over here, I think it's very clear to everyone that it's very thin. This is not thick, it's thin. There's an obstructed blood flow here, which would likely lead to hypertension. Because again, think about the hose. If I constrict the hose by that much, the water is going to spurt out way faster. The blood is going to spurt out way faster here. We're going to see hypertension that's going to harm other parts of the heart that could lead to a heart attack. So when we use a stent after, so when it says post, it means post-operative. So after we put in a stent, then everyone can see here how it elongates, right? How nicely the stent is in place, and then these blood vessels are nice and round, nice and open for the blood to flow through. And this lasts over the course of time. This lasts over the course of 2 years. This lasts over the course of 4 years with very minimal letting out. So this kind of shows that over the long term, for most patients, right, for 91% of patients, we see that this kind of drug-eluting stents, when we put in, works, and it helps the patient in the end. So does anyone have any questions on that? On stents, on blood flow, or on just valves in general? Or sorry, arteries in general? All right, good. I'm glad everyone is absorbing this and finding themselves on top of it. That's always great to hear from an educator's point of view. But again, do type anything into the chat if you want. So now I wanted to look at a potential innovation that, that is going on in the status quo. That how do we combine artificial intelligence, that's what AI stands for, artificial intelligence, machine learning, the ability for programs and algorithms that we code to go and teach themselves and be recursive and go and improve on themselves based on a data set that we give it. And how do we combine that with CT scans, with scans that look at different parts of the heart to go and improve heart health? So before, I mean, you can all see that in this scan, this isn't, you can all see that in this scan, these aren't very well visualized, but this is some of the best we can do with science, some of the best we could do in the past with looking at the different parts of the arteries and different parts of the heart. So there's something called heart flow, which is an algorithm that is like a new kind of technology in the world, which basically uses deep learning algorithms to visualize these different arteries in the heart and build three-dimensional models to see, well, are they obstructed? Are they not obstructed? So in this image, this is a very clean image, right, for educational purposes. It's very nice and clean, where it's obvious that there's a huge difference between this and this. It's very clear that this is nice and thick and this is nice and narrow. That's not always the case. Sometimes if I was to ask you the difference between maybe this and this, to the human eye, that's kind of difficult to see. So how can we automate that away and have it so that a artificial intelligence, something we're coding, is kind of visualizing this? And I believe there's something in the chat. What if a plaque forms around the stent? That's a very good question. So that Adwina kind of asked this question. So what if when we're looking at the stent back here, what if a plaque forms within it? So the issue here is that that does happen completely, and that would lead to a heart attack. So we need to treat that differently than if we just had, let me find the disease right here. Perfect. So we need to treat this disease differently than we would this disease. So again, if there was existing plaque and we had the stent kind of displace the plaque and kind of get rid of it, that's all fine and good. But then if, let's say, our patient continued eating unhealthy, our patient continued not exercising, we would see plaque buildup on top of that stent, and that could lead to a potential heart attack. We would see plaque buildup on top of that stent, and we would see that reconstruction of everything. So some people have been trying to get around this by making drug-eluting stents that combat lipids, that combat cholesterol buildup, and release unique drugs that kind of prevent cholesterol from clumping and calcifying as plaques. But those aren't very well researched into. So that is a definite issue in the medical community, that, well, if you have a re-plaque buildup, then that could also lead to a re-heart attack. So what are ways that, one, we can counsel patients to better listen to our advice and to better take on a healthier lifestyle and eat healthier and exercise? And two, how can we address it with bioinnovation? So we have plaques that displace and prevent cholesterol from calcifying and clotting. How can we develop new procedures which maybe aren't as invasive that can dislocate plaques? So that's definitely a lot of talk in the medical communities, and that's a very good observation. Thank you, Adwina, for asking that. So back to visualizing this with artificial intelligence. So to kind of show you the scope and scale of how amazing this technology is, before we would have, something like this to visualize how does a artery or something look. But now with heart flow, we can use artificial intelligence with CT scans to get very dynamic, very detailed visions of how our arteries look, of how everything looks, and potentially if we were to visualize a stent within these arteries, how would that be implemented? Where should that go? How would that snake around and have this unique conformation? That can help us design stents. That can help us keep an eye on the oxygen saturation levels, on the blood flow and the blood pressure levels, and that can be very, very unique and innovative. So that's just a technology I wanted to make everyone aware of. Again, we're not going to learn the intricacies of the coding involved in these deep learning algorithms. That's just something interesting that I wanted everyone to know about. And then the second thing that we might encounter for our patients is the failure of valves and muscle tissue. So first we talked about obstruction of the coronary arteries. So we talked about arteriosclerosis and atherosclerosis, where we see either plaque buildup or we see this kind of constricting and we need stents. But now another issue can be just with the valves themselves that can also cause a heart attack. So valvular heart disease, and these are all less important, but this is just to give you a scope of how big this issue is. The Mayo Clinic, which is a big research organization in the United States, kind of shows that the prevalence of severe valvular disease increases with age drastically. So everyone can see this almost exponentially increases at some point. And this is a very underappreciated area of science that not many people look at too much, because when you traditionally think heart attack, you're more likely to think of the previous obstruction than actually the issue with the valves. But it's a growing public health concern that's really been growing the status quo, that over the years, the number of heart valve replacements in the US alone have been, growing rapidly. And this is just up to 2011. I think it's over doubled at this point. So there's a huge change, there's a huge increase and a huge necessity for it. So a normal healthy heart valve opens and closes like this. So does everyone see when it's closed, it's fully closed, so blood can't get through. And when it's open, it's fully open, so blood can cleanly get through. But if I have a diseased valve, right? If my valve is degenerated or diseased, if I have valvular disease, then when it's closed, there's still gaps that are open. There's still some blood that can flow backwards still. And we discussed why this is a potentially dangerous issue. That it's the same issue with the car traffic stop signs, where if one car is supposed to stop at a stop sign, but the stop sign isn't there or something, then the car might move backwards. I mean, hopefully no one's dumb enough to do that. But for the purpose of blood cells, they don't have intelligence, right? Blood cells can totally move backwards, and that can go and interfere with the traffic. Obviously, that causes traffic accidents. But in this case, that can interfere with the blood flow. It causes a phenomenon known as regurgitation, which can, again, which can deoxygenate our blood, and that can lead to issues within the heart. And again, when it's open, you can see that, well, compared to the actually open valve, it's not very open. It's only slightly open. So again, that leads to hypertension, that leads to inadequate blood flow all over the body. And these are again diseases associated with that. They're less important, but I just wanted to show you how this looks like in real life. That these diseased valves, like they don't look anything like normal valves. Even when they're closed, you see small openings where the blood can backflow. Even when they're open, you see that it's not as open as it should be. So there's not as much blood flowing through. So that's very, very dangerous conditions. So scientists have discovered bioprosthetic valves. So these are xenografts. So xeno means foreign, means alien. So xenograph is actually when we're taking tissue, like heart tissue, from other animals, like a cow or a pig, or even in some cases, horses are less common, but mainly cows and pigs, because we can engineer them to have very similar heart structures as humans. We can use their tissue to go and build these valves. Because again, when we think about it, what are important properties that a valve needs to have? A valve needs to open and close properly. They need to be elastic. They need to be responsive to blood. And these are all properties that other tissue in the heart can have. So the pericardium is like a tissue layer that's around the heart. So once a cow dies, we can harvest their heart, and we can take the pericardium, the tissue around their heart, and we can construct it into a valve. We can take the once we take these valves, we can stent it. So we can integrate miniature stents within these tissues to make sure that they have the conformational shape of a valve to open and close. So the way that we would put this into the heart in the status quo right now is through surgery. And again, we're not all trying to be heart surgeons here, so we don't need to go too much in depth. But the basic overview is that I cut into the patient's chest, and over here, if you see that this is where a valve used to be, where the diseased valve was, we put in the new valve into the diseased valve. So sometimes there are risks with taking out a diseased valve that we don't want to incur. So it's easier to put in this diseased valve into, kind of nested into the actually diseased valve and put it in there. In other cases where it's necessary, you can take out the valve and you can excise the valve, but that's less common. But nonetheless, you have this xenograft, this valve that was constructed out of a cow's heart tissue or a pig's heart tissue that we kind of sew in place into the heart. It's almost like sewing in a button on a dress shirt or something like that, or a sweater or something like that. That we kind of sew in this artificial valve to function within this heart. So the future is very murky in heart science. There's a lot of innovation going on, a lot of potential. Some have high efficacy, some are very interesting that would be very biocompatible, but we haven't found a way to refine them and really have a working model. So an example is a silicone artificial heart. That, well, if you have heart disease, even if it's a valvular disease where you have to undergo intensive surgery, or if you just have a heart attack and you have heart tissue death, then is there a way that we can have a completely artificial heart that we put into your body? So right now, we have, yes, there's been silicone artificial hearts, but they only last for about 3,000 beats. So past that, they haven't been shown to be too effective. And that's something that scientists have been trying to optimize as of a few years ago. So that's a still murky area of science. But another area might be when we're looking at valves specifically, to revisit our lesson last time, it might be like bioprinting valves might be a very, very possible solution. So I covered this last time, and again, I'm going to give you a 5-minute overview of how this might work. That will fundamentally, 3D CT scans are like stop motion films. The same way that obviously these yarn cute toys aren't actually coming to life, right? That if I take a picture of them in one position, then up, then up, then up, and take like 100 pictures of them just slowly going up, slowly going down, and put them together, it looks like they're jumping. Like that's how stop motion films happen in the old days. The same way where if I take, 100 different pictures of me waving and put them together, it makes it look like I'm actually waving, even though they're all individual pictures. So likewise, that's how 3D scans operate. And we covered this last time. I'm giving everyone a quick review. That if I scan every single section of the heart, bit by bit by bit, and take like hundreds, if not thousands of different pictures and compile them all together, I can make a 3D visualization, a 3D model of what I think the heart looks like. So in this case, I can do it with a heart valve. I can visualize a 3D model of what I think the heart valve might look like. So I can go and image a heart valve and see and develop a CAD model, a computer animated design of what does a valve look like, what are different, grooves, what are different sizes, what are different nuances and kinks within the design that I want to have. And based on that, I can print the scaffold for this valve. And again, we covered this all last time with what are scaffolds, what are bioprinters, what are Bioinks. If anyone wants a refresher on that, you can watch the previous video that we have from last week's class. But as a quick refresher, bioprinting is like normal printing. The same way that if I was to take a picture of something and print it out, what my printer does is converts digital pixels into physical spots where it should place colored ink. That's exactly what a 3D printer does. But it takes this 3D visual model and places each pixel with a region, with a specific coordinate in space, and prints accordingly a scaffold. And these are real life scaffolds. These were developed at Harvard University, I believe, of heart valves. And everyone can see here these are valves that when they close, they obstruct heart flow. When they open, they let blood go through. So these are scaffolds that were printed and can be implanted into humans. And then there are questions of, well, if you want to get xenografts from other animals, there's ethics concerns because yes, we're taking an animal's heart. There's issues with biocompatibility because, well, what happens if your body rejects this tissue? Because as far as your body's concerned, this is tissue from a pig, from a cow. It could be a foreign pathogen. Your body doesn't know. So your body could go and attack those valves. And that's happened before, where your body starts having an immune response and your heart swells up because your body develops, starts sending all these antibodies and all these protein kinases and all these eosinophils and killer cells, natural killer cells, towards these valves because they think it's foreign tissue. That's a very dangerous condition. But if I was to use a 3D bioprinted scaffold, and I was to implant it with your own stem cells, your own mesenchymal stem cells, maybe through iPSC, where I take your healthy skin cell, degenerate it back to a stem cell, and then replant it into these heart valves, then your body actually, it's seen to be biocompatible. It develops complex structures. It goes and integrates into the body's anatomy and physiology. It goes and integrates into the vasculature and starts pumping blood as normal. And your body recognizes it as your own cell because it's seeded with your own cells, your own stem cells. Those are found to be very effective means of kind of repairing the heart. So that's all I have for everyone today. I hope it was a quicker-ish lesson, but I hope that was informative and helpful.